talk today is to really look at how do we optimize a site? How do we use things that enhance the outcome for the patient, reduce risk? And by the way, we work in a business environment. It has to be cost effective and treatment efficient. Having somebody come and having everything done in one surgery and done in 4 months, to me, in a lot of ways, is the epitome and the pinnacle of simplicity. And that's my goal. So everything I do is no more than 2 surgeries. Try to design it so it's no more than 2, and it's with rare exception that we can't manage that. Question is how to do it fast, and how do we do it in a way that doesn't hurt? Who wants to be known as a surgeon that hurts patients? All right? I want to be the guy that doesn't hurt and has no swelling, and people come back and go, wow, it didn't hurt. And that's a very, very common finding in my practice. I had privileged to work with a number of contributors and co-authored and co-edited this book with Doug DePorter on minimally invasive surgery. And this is where I've learned and cut my teeth over the last 15 years, back from Maurice and David in '98, doing immediate aesthetic zone. I learned from Fouad Curry in the same time window how to do crestal, osteotomes, a split bone technique that was shown today, including the Freodent saw. I still have one of those that I use occasionally. So it's something that's a part of what I've been doing for a long time. And I'm excited about doing sit-down surgery, and for an oral surgeon, there's not many of us, but I want to practice and enjoy my health and enjoy it so I get better posture, and we can complete these procedures in a way that really is productive for us. So this is an example of a case that I'm doing with a mini flap, doing navigation surgery, and in the navigation device you can see the yellow line around the side that's showing us the depth that we're drilling. We've done 3-dimensional planning, so we have a cingulum positioning for screw attention, and we know our angle, and we can see here at the 13 millimeter depth we're 0.1, 0.2 off of our plan. So that's me drilling using the guide to know where I'm going without anything in the way, that I can see at the same time, and I can change if I don't like where it is. And in my practice, I modify the plan about 10% of the time because I'm not always that accurate clinically, and telling where the buccal bone level isn't always very predictable on cone beam. So these are the components of the system that we use, and in doing this, we have all this different computer stuff, and you know, I love guys that are computer nerds and understand all this, and Ed, who's in the audience, did a lot of work with the design and development. I'm not that person. I'm the guy that puts legs on it and makes it work and makes it run efficiently. I know how to use the technology, but this isn't me. So we all understand 3-dimensional fields of view. We have to get a tracking array. We have to get a volume, and then we take and calibrate, and in calibrating it aligns the tracking arrays. So this is a simple explanation for how we coordinate the dynamic navigation. And the workflow, which is now where it comes back to me and to you, is in clinically, how does this work? And it works is my staff heat up the fiducial, they pop it on the tooth, and we take them to cone beam, scan it, they calibrate it. I get the plan, and you'll see a couple of cases with the planning done, and then we go to surgery. And this is something that we do have to do sometimes in the same day. It takes about 20 minutes from hitting the office to where we can have them in the surgery room. It's not part of my normal workflow. I'd rather not do it. But here's an example of this case with the implant going in that we saw the initial drilling. We can see the angle. We can see the position as it rotates around on the yellow screen till it gets to green, which is right close. And I go to red because I want to be sure I'm right there. And with the densiburs, you have to drill a little deeper for some of the implant systems to make sure that you get it all the way seated, or you'll get to take it out and redo it. So this is an example of placing the implant and working it into position. Occasionally we do it with the hand driver. So sometimes I'll stop slightly short of the site and then finish it with checking the vertical dimension to make sure we're 3 millimeters, make sure our gap is the same, and put it all in. Well, that's all good, but do we have evidence? So this is a study I got to participate in with R.W. Emery, who's one of the principals, and Mike Block. And we did this study on a number of patients, almost 500 patients, 500 implants. And you can see as we look, see if I work now. No, I still don't work. All right, so I have no pointer. So there's all these patients, 714 implants, and I think the thing to look at, the blue is a freehand, and the red is a fully guided. Partially guided is in between, so you can see on every parameter that we can measure in the post-op imaging that we're better off with navigation, whether it's guided or unguided, but this was with guided. So if we look at the navigation, here are the first 10, 20, and 30, and 40, from the orange down to the green. The red's freehand. So this is a graphic representation of the first 40 cases, and this is Mike Block's learning curve, and you can see how each time he did it, he got better with each different case. Okay, thank you. So this is something that you see, there is a learning curve, and you have to make your staff do it for every case. You can't just jump into it and do it willy-nilly. You learn it, you do it, and now that I do it every case. Dynamic navigation and versa-burrs, and they go together like a lot of really good things. So if we compare it to the workflow to do a traditional surgical guide, we have a lot more things that we have to manage. We have to do these components, and there's usually a lab and a milling. We can do some of that in our office, but it's not as efficient as you think, and it takes some time. So to me, this is way simpler, but this is the one key. Of all the things that are important on this, limited mouth opening is huge. When you have a static guide, you have the height of the guide sleeve, and you have to have the drill longer. I can do second molars, and you'll see a video a little bit later, mandibular second molar. My immediate rate on them is about 70%, 75. First molars are about 90%, 95% of before they walk in the office, not once we've scanned them. So it's a very high predictability in terms of outcome, but the limited mouth opening, because you're not looking at the patient, you just have to verify it one time with the periapical, know you're there, and the rest you don't even look at the surgical site for the most part. So if we combine these two, we really can see some improvement. So I'm going to show you a traditional approach to a healed site. We have a patient that's losing a couple of teeth, bad periendo problems. We clean it out, clean out all the defects, do a graft. This is a porcine xenograft, or Z-core, which isn't the same as a bovine and some of the others that don't turn over. It behaves more like a mineralized allograft. And so we go through this combination with a dense PTFE membrane and a classic technique. We do pull-out, we do our planning with our traditional navigation. And now we take the patient to surgery, and I'm going to harvest some cores here at these sites and then finish the preparation. The core came back as greater than 50% vital bone. There's some particle remnants, but this is just at 5.5 to 6 months. Now we take the navigation to the surgery and finish the site preparation, place wide platform healing abutments, and here we are with the restoration. And it's amazing the contour and the quality you can get, but I can't understand how the value of the two crowns can be so great a discrepancy. Anybody explain that to me? Whether it's two different blocks of porcelain or no, not porcelain. Guys, it's 6, how late is it? I'm tired. Zirconia or whatever the material is, or maybe they did one crown in each. So if we look at crestals, this is one of the real pluses of osseodensification. So for years, I've been doing crestal elevations, and I figured out ways to do most all of my crestals without having to do laterals, and my patients like it because it doesn't hurt. I'm at a place, I'm an oral surgeon, I haven't done a lateral graft in 4 years. All right? So that's a big difference, and Versa has changed that. Dr. Toffler and Michael went over this really nicely, talking about different anatomical assessments with the slope and the sinus floor angle and those kind of applications, but the traditional osteotome technique works. We can get some places with it, but does it really make it better? I found over the years it has made it better, but now that I've done densification, there's a big difference between an osteome preparation and densification. And you all had vertigo in your patients? Yeah, I've had 5 now over my career. 3 of them were nothing, 1 of them was significant, and the other one lasted for about 6 weeks. So it can be something that's a problem, and with densification, we completely miss it. So look at this case. We have on the left side of the screen the immediate. We're taking out our tooth, doing 3 implants for 3 individual crowns. We've done some apical flap positioning, and you see the intraoperative, and here we come to the final restoration. Look where our screw holes are. Okay? We want our implants to be ideally positioned, adequate implant dimension, and we want the screw holes where they're not going to compromise the aesthetic or the functional cusp. So combining densification and navigation is a huge plus to preserve and enhance, to make something with what little we have that doesn't hurt and is cost and time efficient. So this is the mantra. I'm going to come back. Both these technologies together are better than either one alone. Okay, you hear me? Both of them together are better than either one alone, and you'll see as we do some of the videos. So here's a crestal elevation, and with this, we'll see on this video, we're going to take and start doing an initial site preparation. You can see the depth, you can see the angle and the positioning. This is a healed ridge, which we're doing these first few cases on. And you don't have that much inclination or change because you don't have septa or slopes to drill on. So this is pretty straightforward, and this is a full arch case, and you can see the imported digital workflow that we're doing in terms of tooth positioning. Here we're doing a molar with a small bump. So to me, a lot of these cases, you can move them forward with a very small amount of work. And it's a large number of cases, and this level of Versa application, you don't have to be a rocket scientist for. Almost everybody can learn how to do this and do it well. Okay? When you get to more advanced techniques, it's different. So on a bone-added perspective, how do we work bone-added? In the old days, this is how we did it. We took an X-ray, we do 3D now, but we do osteotomes. We drill slightly short of the floor. We break the bone, add bone, break the bone, add bone, break the bone, add bone. And at the final dimension, we bump the osteotome up to the normal size or depth of the implant, and then we place the fixture. And you can see a nice elevation and a nice bone margin. And here's the case after 42 months. I'll take that. So what we're doing now with densification is building on what we've already done in the past. So here's a case at 13 years. This is 2 years ago. Okay? So we know that these kind of techniques work, that they hold up. We just have a better way for most of them to be able to do it. So let's look at the bone-added technique, and here's the sequence on this patient. So you're going to see the drills, you can see the bone added, you can see the elevation and the implant in position. And so we'll look at the case. It's the one in the orange box, so this is different slopes, so I teach different ways to do it. This is this case. I'm not teaching it because it's not a sinus course, but here's the elevation. That's a pretty significant elevation, isn't it? It's a moderate sinus angle, moderate to narrow, and it's a moderate slope. So that's just one of the assessment tools. Here's the patient clinically. And you can see he has good attached tissue, fairly a significant sinus defect. Here's our drills. We're going to go through the 2-0, the 3-0, and work them through the depth and positioning. And here we can see at the 3, this is probably 4-0, that we can see we've got the dome. We still have the membrane intact, but we've got a dome. The first time I looked at it, I'm going, oh gosh, I got a perforation. No. So this is now where we start. We've got our dome, so now we take NovaBone, and this works really good. And I learned this from Maurice 3.5 years ago, or about that time at Osteogenics. And so I brought it home and started doing it, and I like it. It works great. Some of the other min-demon combinations can work as well as an allograft, but the flow of this is better to get it mobilized. So I've done some combination where I do the initial with the NovaBone and then add allograft after it's already tented, but that's a different topic. So we add the NovaBone, now we go to our 5-0 drill, we reverse spin it, push it in, now we do it again and again. And we check it with a PA, and it looks beautiful. So here's a site with the osteotome in position. So I haven't advanced it into the sinus very far yet, about 2.5, 3 on the downhill side of the slope. The downhill side of the slope is where you measure from, right? Okay, so here's the implant, the burr in position. Now we've placed the implant, and you notice I haven't gone all the way to depth. Usually I'll go close. This is a 5/8 by 9, and I'll go close to depth, and if I'm not certain, especially when I don't go to depth with an osteotome, I don't know how deep it is. So I'll take a check x-ray 3/4 of the way into the positioning. If I'm really comfortable with it, then I'll just go straight to depth. But the deeper or the greater the elevation, then I usually stop 1 millimeter, 1.5 millimeters, 2 millimeters short and do the periapical. And that lets me see where I'm at, and then I can screw it in the rest of the way. Look at the torque on this, guys. Okay? I mean, I see 70s, 80s, 69, 67. When I did it with the old burrs, with the implant systems I used, this is about 8 to 10 ISQ readings higher. So I get pretty good primary stability with these systems. But here we do apically positioning the flap. And I find that this is just as effective from a pain management. This doesn't hurt. So if I apically position the soft tissue, I get deeper vestibule and I get better keratinized tissue, and all my referrals like it. I don't do punches. Okay? That's the way to do it if you have enough tissue. I'd rather have extra tissue and do a Palachi to the mesial or distal, or I don't want to throw it away. So twice a year I'll cut it off, but most always I do an apical positioning. So here's the drill sequence again. It's highly effective, and it's not a big owie. So let's move on to ridge expansion. And I spent a lot of time working and developing different ridge expansion techniques, and I really like it, and the older I get, the less I do, especially in the more classic kind of sense. This is a flapless or a limited exposure, and you can bend the bone, you can change it. These are examples of the way I thought about it before, and now Sulla's added a third category. Osteocondensation, which is squishing the bone, which is like an implant or like an osteotome. This is in the mandible, or making bone cuts for osteomobilization. And now we've got densification, okay, and or combination. So to me, the future is, where is densification going, and how is it going to continue to change what I do? Look at all the instruments I use here. There are still cases where, when it's all cortical, that this is one way to do it. But when we've got a marrow component, then we don't have to use this. So the indications are changing. So on this, for a traditional ridge expansion, if we look at the screen, you can see the first 3 from the left side of the screen are what we would very simply do with densification. When we get a little further over on the ridge expansion timeline there, those cases are ones that I would tend to do with a more traditional approach, but I can still do them with osteodensification. So we'll see a little bit. I'm still in learning curve. Ridge expansion is trickier, and a lot of times clinically it's not very rewarding because you don't see a lot and you end up overgrafting it anyway. So it's kind of like, well, why should I do all that work for the site? But it does change the site. So this is example in the mandible of a case using a screw or a traditional kind of ridge expansion approach. And here is where we've got condensation, and then we put the implant in, and what happened to the bone? It fractured. Okay? So it's something that the diameter and the pressure from the implant on a conical surface, we can have that. Now, would we rather still have autologous bone on the implant surface and overgraft it? Yes. Okay? With densification, it won't break, but it could break if your implant's too big, but you're not supposed to under-prepare, right? The hard part for me with the densification, I'll show you in the case coming up, is my staff want to suck the bone away. You know, the little cone of bone. So that's something that's worked. So here we're going to overgraft it in just a traditional GBR with a single stage protocol. And we move the tissue around a little bit. And here's the pre and post-op. And I'll take that result. This is a traditional approach with an overgraft. So it works, but where are we at in the efficiency? And when is this better than densification? And the more and more I use densification, the more my indications are shifting, and I look forward to applying some of the new things I've learned here, especially with immediate. So I'm going to talk about that in a bit. But here's the graphic for an osteodensification ridge expansion. Here's a case that I've done with it. We're taking, moving, bending the bone. The hard part's to not have your staff suck away or wreck the bone while you're in the middle of doing the case. So that's the tricky part for me. So now we place the implant with navigation, and you can see on the top left screen, I'm about 1/2 millimeter deeper because I was missing a little bit on the buckle. So I'm cheating and lowering the implant a little bit to reduce the vertical height discrepancy. My ISQ is 81 and 78 on the second reading. So that's real high, but we'd expect that. On the far left, you can see that I have plastied the bone around it, so I didn't have a really high lingual plate, and I blended the contours into the adjacent teeth. So that's something I think is real important, to have an acceptable prosthetic result and not have a problem with abutment impingement or emergence. So if apically positioned the soft tissue, like I've showed you, and closed over it. Oh, the only thing that I had that was different there is this is different. I used amnion chorion. So y'all are using the LPRF. I get the same growth factors from something out of the bag, and this works really well, and I'll talk about it a little bit more later. So we move through this traditional kind of grafting on top of the ridge expansion, and that is a very predictable procedure. So we're going to move on to immediates. And immediates, to me, along with the crestal immediate, is the sine qua non. That's something that I can do predictably every day in my practice. And we want to place the fixture into the mandible. Here's a traditional case I'm just showing you for reference. I've done this for 10 years. And before that, I didn't do molars very often because I didn't have an implant macrogeometry that I could predictably do it with. But I've got 10 years and 10-year data doing immediate molars. So this is something now when we add navigation, it makes it more predictable because I know where my screw axis is going to be, and you can't tell how many times you think you're way more buccal than you think. And you end up with the implant even more buccal than you prep it because it pushes off which wall? It pushes off the lingual wall. So with navigation, I take the drill and I over-prep the lingual and I over-prep distal into the furcation, so when I screw the implant in, it doesn't kick out. So I'm throwing the pass where the receiver is going to be, not where it is where I'm drilling statically. So this is something that as you learn, if you're a skilled surgeon, you'll pick these things up like right away. It's intuitive. But if you're a learning surgeon, navigation doesn't make you a surgeon. Okay? Navigation doesn't make you a surgeon. The machine doesn't always work, but neither does a static guide, does it? Who's had one that came back that didn't fit? I bet there's nobody in the room, right? But this just shows you the process, and it fits with most everything, but I learned to put the graft first and spin it in. So that's going to change how I do it because it takes me longer than it would do to leave the drill in, pack it, and then reverse the drill. So I learned that at this meeting. So thank you, Sulla, and the folks that showed that. But even so, we've got a 70 ISQ. This is a highly predictable procedure, and it's in the mid to high 90s after I've scanned them that I can do it. I need 3.5 millimeters from the root apex to the nerve. Okay? I can steal it away sometimes in 2.5 with enough apical primary stability. But here you go, you can see it. And second molars are trickier because there's more undercut and the nerve is higher, so you don't get as much margin and you have to watch the inclination. So even as far as far palatal as I was with that, look where the access screw is. And you saw how big my buccal gap was and the angle of my placement. So even doing what I'm showing you, sometimes you can be there. Imagine if you weren't doing it the way I showed you, how far buccal would we be? Okay? So this gives us the opportunity to move cases forward in a non-owie, productive way. This exact same thing was done on the other side at the same time, but I didn't have time to show the duplicate. So this is an example now of this kind of site preparation. We do the calibration, we check an adjacent tooth to be sure that it's accurate, and that's as far as I look at the patient again. Now I got to look at the screen, and we work through this. You see how I'm drilling from the mesial distal because I'm engaging the septum, and see how I'm uprighting it as I get a purchase. So you'll see that on the first 2, sometimes 3 drills, you have to move it through that kind of a sequence. And so you'll see on the next drill series, again, so we go 2-0, 3-0. Sometimes if the furcation won't accept the full size, you got to go back down to a 2.3, or at 4-0, you got to go down to a 3.3, or at each size, because as you drill the hole bigger, you're running into more bone, but you don't have bone on the mesial, but you have bone on the distal, right? You have bone on the lingual, but you don't have bone on the buccal, so it tries to kick you out. But the burrs really don't chatter very much, and running them in reverse to start them and then cutting mode, or vice versa, is helpful. So I flip back and forth between forward and reverse sometimes to get purchase. See, again, distal, and now right at the very apex, I'm uprighting it. And I'll also take the burr, like I described to you before, and intentionally burr out extra on the buccal, on the palatal, and on the distal, wherever the furcation is. Upper molars are slightly different. So here we go, we're putting in the implant. So this is just routine in terms of shooting it. And with some of the implants with more aggressive threads, they wobble more as you're first starting to seat them, and they don't line up almost until the very end. So you'll see how it's kind of weird, and now as we're getting close, we've got pretty good angle, pretty good position, and I'm about 1/2 millimeter. A lot of times I'll stop there, check with the probe, make sure my gap is good, and finish seating it with a hand instrument or with the existing drill stop, reverting to the original measurement. So we go through, we do the ISQ, and we do a graft, cover it with amnion chorion. This is the normal 2 PTFE or 2 glycolon sutures. You tie them upside down, which is a different way, so they're easy to take out afterwards and you don't knock the amnion loose. So let's look at a little more aggressive kind of a situation. What do you see in the mesiobuccal of that molar? I'm an oral surgeon and I can see that recession defect across the room. So you perio guys must be like really tuned into it, right? What do you think, Richard? Yeah, it's perio. So we're going to take this tooth out, and the patient's going to have an implant both in the first and second molar sites. One's immediate and one's delayed. So we've done our planning on the navigation. Here's our case. We're placing the implant, so we've got a buccal gap, we've got an adequate bone margin on the distal fixture, and our ISQs at the immediate are 71 and 91 on the healed site. Usually it's not that much discrepancy. Here we've done a graft around the defect, and we're covering it with the amnion chorion. So this BioExclude is a great barrier. I love the growth factors, and I'm going to share with you something here that's not quite as impressive, but we'll talk some more. This membrane has highly angiogenic properties. It's immunoprivileged. It's antibacterial. So it does a whole bunch of things. It causes ingrowth of vessels, and it has a host of growth factors that are in it. But more importantly than growth factors in it, they're released biologically over 5 to 7 days. There's not a big bolus. PGF, GEM21, PGF, it's gone like in 20 minutes to an hour. BMP is gone in a day. So the difference in terms of the biologic capability, and then we combine this with densification and enhance the wound, it's really something. So we can see impact on wound healing, we see cell recruitment and angiogenesis and vascularization, but also there's a study in J. Perio where they showed a significant difference on right side, left side split mouth study in discomfort or pain. So it's something that there's stuff behind it, and it all works together to have folks go home and come back, and 95% of them say it didn't hurt at all. I took the ibuprofen you told me, but it didn't hurt at all. So here we are back to the case. We're going to take that, and the other thing that's really good about it is you can stick it right up and on the healing abutment. Okay? And what I've seen with this over time, so here's closure. Look at the defect we have and compare it to the posterior where you have an apical position flap on the other molar. Here's early healing. Here's 4 months. And here's immediate post-op in 4 months. So this is moderately impressive, but what I've seen from it in my observations, are that this heals from the basement membrane to the epithelium. All our other grafts heal from the epithelium. That starts at the graft and goes deeper. So it kind of violates Lincovicius's rule. So this is something that's in the middle, and I look forward to reporting to you more, but that's what I've seen on a number of cases. I'm not going in to show you all of it today, but here it is on the occlusal view. So if we can harness that to help us with soft tissue at the same time we're doing navigation and densification, boy, is that a plus for immediate wounds or what? Right? And it doesn't cost very much money. So here's an example of another case. And we're doing a second molar, immediate second molar. So here's a video of this case. I spend more time cleaning the wound than I do taking out the tooth. Okay? And if it's dirty, I put betadine in it and rinse it with betadine and then re-scrape it and re-clean it. So that's one of the tricks I learned from my surgery residency with contaminated wounds. So endo-treated teeth or fractures, that's how we do. So again, with this, you'll see drilling distally a little bit on the screen. Here I'm making a plan adjustment. I was too mesial and tilted distally, so I'm going to go in surgery, move the implant back, and then rotate it more forward, and now re-prep it. With the VersaBurr, I can just grind it and shape it and rechange it just like any other time. So the immediate wound, also see on the cross section right here. See how close we are to the lingual plate with the undercut? So when you start hitting that bone, the burrs give you a real feedback, and you have to work a little bit and pump it more to make it cut into that lingual plate. But I want to cut into that lingual plate to almost dehiscing it because I want my implant as upright as I can get it. Okay? So this design with the BioHorizons works really good in the undercut because it has a strong taper and a good thread pattern, and it comes out really nice in the 9mm as a workhorse implant for both the mandible and the maxilla. So here we're just working through the different drills, shaping it, changing it, and you can see there I'm pushing distally and now I'm uprighting it. So to an experienced surgeon, we're doing that all the time. Now I can see it real, but now I can slice down between things. I can go lingual to the nerve because I know where I'm at. I can control it and see it real time. So here we are placing the final implant. Again, I go to the tooth for confirming the surgical site and the calibration of the implant. And now we're going to take and screw it in. And you can see on the top right the periapical. With this implant design, you have to slightly over-prepare the apex or you'll bottom out. So it's pretty common to just slightly over-prep it like you saw. So then we take this defect, I evaluate it, do the same thing. I transition it from the mesial to the adjacent tooth. I take down the lingual so that I don't have a huge height discrepancy, and then I adjust the vertical based on 3mm from my buccal bone level, okay? And if I'm short of tissue, how hard is it to stick a wedge of connective tissue in here? How hard would it be to take a piece of tuberosity and stick it in here? So this is a combined autologous and xenograft in porcine, and now we pack it around the site and go from there. So this is the kind of process. This is a second molar, and I did a case on Tuesday before I came, that the lady could only open 2 and a little bit finger breadths, and I'm doing a second molar. So I had to drill the first holes with a shorter one because the VersaBurrs were too long. But once I had the hole half opened up, I could kind of sneak them in and then grind it out. So I was able to do it at an angle, and I knew where I was because I had the dynamic navigation. I couldn't do that with a static guide, and I certainly couldn't do it if I'm trying to look at the surgery and see because I couldn't tell anything. And my assistant couldn't see anything. So this works us through. We can see the contours and the crown position. So we're moving into the next component here is aesthetically. Well, we saw lots of very nice cases from an excellent host of speakers both days, and I'm really impressed with the meeting, and I really am glad to be part of it, Sala. Thank you. So here we have this upper lateral. So that's 1-1 in Canada, or in the rest of the world, and to us Americans, it's 7. So we go ahead, we're going to take that tooth out for this lady. We're going to evaluate the site. She has a reasonable biotype. I want still a 2.5 to 3 millimeter gap. So I've learned this the hard way. Howard Park and I have learned this together, and we've been good friends and struggled over the years with different ways and how to make it work. Here you can see the planning, going up and down to check my screw access, make sure I'm not too close to the adjacent roots, that I'm parallel. Now we're doing our drilling. We engage it. We go in and out. We pump it. The harder the bone, the more you got to pump. The pumping you don't have to visibly see. You just have to pump it and relax it, and you almost don't even see the pressure shift and change. So here we're placing the fixture now, and I choose the fixture partly on the buccal gap, but guys, don't forget about the mesial distal. Okay, if you have an adjacent implant, you can get too close. So I'm going to pick a narrower implant if I need to, because I need enough room to the adjacent tooth or implant. And just because they have enough room now, if you have another tooth and they lose it, you won't have enough interproximal dimensions, so you have to go smaller sometimes to have enough interproximal. So here we've placed it, and in this case, I've used a hand driver to finish its positioning. A lot of these cases, again, like I said, I stop a millimeter short, do a check x-ray, check it, and then I finish screwing it to final position with a hand driver because I can see it. So like Richard said, there's a digital part of it, but there's still an analog. I want to see it, I want to feel it, and it works pretty trick this way. So here's the case, follows all the principles that we're talking about for screw retention. And we worked through this lady. I did a provisional the way I learned from David and Maurice and Peter back in 97, 98, 99. And I still do it. I do find I do less of this now. I'm getting less referrals. I'm doing a lot more mediate molars. So for the oral surgeons in the crowd, don't miss out the mediate molar dance because it's really helpful. Bone graft in the gap, single layer of amnion chorion, and place a provisional. And you can see our bone levels, and I'll just take you through. Here she is at 4 months, and here's her radiograph and her contours. The distal papilla is almost filled in. Okay, if the bone's there, that papilla will be there if it doesn't get the space closed. So it's looking pretty good. So let's look again at another mediate case here. So we've got a molar that's in trouble, upper left first molar, and we've got a furcation. So here's what we're going to do. We're going to densify with navigation and optimize the site, bend the bone, use what we got. So here we can see with these different drill depths, so this is just a static shot of what I showed you on the videos. We get to the floor, go a little bit of our dome into the floor, 1 to 2 to 3 millimeters, measuring from the downhill side, whichever that is, mesial, distal, buccal, palatal. It's not a consistent thing. We go through the dome bottom, we know our depth, now we're going to take and add bone to this case. So here we go through, here's the bump, here's the graft, the implant, amnion chorion. Usually there's not very much palatal opening, but there's usually a little bit. The wider the tooth, there's sometimes a little bit of a palate. I like to have 4 millimeters on the facial of the molars. I like 4 millimeters, and I graft this with allograft or with the porcine xenograft Z-core. So those are pretty representative. I don't usually do a third suture. I don't know what I was thinking that day. That's not something, I don't think I've ever even done that another time, but here it is on this case. And I also use the glycolon in the 5-0 with the large needle more than I do PTFE now. But I can tell you this, the amnion chorion doesn't like chromic. It must be the glutaraldehyde in the fixative. So when I was doing open cases, I had to learn that to use PTFE or glycolon. Okay, so stay away from that. A few other things with it too. It doesn't like mouth rinse. It doesn't like spices. It doesn't like alcohol. So anything more than wine. So here's the case with the implant placed. I like the position. I got to choose it. I got to make it happen intentionally from what my end game was. We got to optimize the site. We got to improve the bone and use what the patient gave us. And here's the final restored result in this case. And I will comment on the socket shielding. It was brought up that usually the gingival margin's higher than the adjacent teeth. That's my experience without socket shielding doing this technique. Okay, usually it's very good contour and maintains the shape long time. So here's a planning video. And now we're going to do a similar kind of procedure. So we're taking this as video of this kind. We're going to go to the floor here, and we're going to work through the drill sequence. And we're going to do a bump, and then we're going to take and add some bone to it, and run it in reverse, push it up, go up from our 4.0 to 5.0. Some of the implants occasionally I go to 5.3, but generally 5.0 works good with a tapered implant because the apex is narrower. So we're getting stability from the mid-third of the implant in that 3 millimeters of furcation, and it's plenty. You know, the ISQs are typically, like I said, high 60s, middle 70s, and occasionally higher than that, like I showed you on that one. So here I'm making a minor adjustment for depth because I'm comfortable that I can get to a 10, so I've added bone and pushed it a little bit more. The slope is why I was making sure I had it moving before I went to depth. I could have stopped at 8.5, and here I'm just going up. So the rest is just putting in an implant. And with that, I'm going to move on to full arch. Well, is full arch any different than anything else when it comes to site preparation? Not really, but the planning and the case and where we put the implants is different. Usually they're deeper, they're more palatal, and we want them upright. But that's a different topic. I'm just going to show you a case. This gentleman had all his teeth out and all on 4 in the mandible, socket grafting on the upper, and he wanted to have an upper prosthesis. Here's his healed CBCT, and we're going to take now and do implant planning on him. So we've imported his digital wax up, and we've got the implants, so we're going to go through dropping. This is double speed, but you'll just see how we plan it. It's not any big deal to do. Full arch cases, though, I don't like to plan on the fly. There's too many angles I can screw up, and the prosthetic people might not be happy with me, so I need to look at them one more time, so I like doing it in advance. So here we're just adjusting the position and looking. We've got a buccal palatal slope, and we've got a little bit of a prominence, almost like a septum. And so we're going to densify that and place an implant primarily. So we're just working through the rest of the workup here. And now we're going to go to surgery and place this implant based on where I want the access screw in the final restoration. Okay, and the more palatal usually is the better. So we go through our site preparation. I tend not to use more than RP fixtures on these. I find the emergence is better. If you're wrong, you've got a little more flexibility prosthetically than if you have a wide emergence, and especially on the buccal if you don't have thick tissue. So here you can see us just working through, working up to the depth with the drill, advancing it, and you can see we're going to be lateralizing the palatal aspect to make some of our osteotomies. So part of our crestal is vertical and part of it is lateral. And lateral's not so bad. It's a good way to do it, like we saw from a few of the other presentations earlier. So here we're just working through the drills, getting our elevation. This is the anterior site now, and we're just going through normal placement. This is a fixed guide for full arch. So we scanned it, calibrated it, and that guide is screwed to his jaw for us to do this surgery. So you have to make sure you put the screws where your implants aren't going to be. So I didn't go through all of that. It's a very doable and different protocol, and they're working real hard on some advances toward fiducial free. So we'll look forward to that being out in the next little bit. So here's a case. Prosthetically, any restorative doc's not happy with this? Okay? This is what we can do, and we can do it dynamically with densification, all at one surgery. The only problem is this gentleman lived in Alaska, and he didn't do anything he was supposed to do. His story's a little long, so I'm not going to tell it all to you, but I'll tell it next time. So let's go one last full arch case, and we'll clean up here on time for you. This is an example of using it in the mandible. Great. Here's what we're doing. I'm looking for the tilted placement. See the nerve on the facial? I'm sneaking right up beside the nerve. So I know that I'm going to be right. I can place this at an angle. I can know that I'm there and safe. Now I'm drilling at an angle. It's a little goofy when you're drilling sloped on the models, but it works. So you can see we're also typically pretty dense bone in this area. So we're going back and forth, pumping it to get it to expand and condense. And we have to keep working it. So this is a place where you might have to go forward cutting and go 2-0, 2-3, 3-0, 3-3, and then check for what the density is. If you're going to 4-3, 4-0 to 4-3, maybe I do the top 3/4. But this will usually torque out. This is one other place where there's one motor unit that has an 80 Newton torque. It's from W&H, and if you're doing navigation surgery, you need the 80 Newton torque, and it's not an expensive unit. It's in fact less expensive than a lot of them. So it's a great machine, but you need it if you're going to do navigation because you need the 60 to 80 difference to be able to get most of the implants in, and it still torques out. So here we go with the fixture going into position. I'm probably not going to get all the way, and then we'll finish it by hand. Okay, so I popped out, we finish it by hand. Here's the 4 copings. You guys know this, so whether we're doing whichever model, we still do traditional pickups for the most part, and this is the way the patient left that day, and this is, I think, the week follow-up when they came back in to see me. So being around the nerve, having tricky spots, okay, there's advantages to this that I'm not sure I can trust a static guide, because what if we've done a reduction guide and our yaw's off just a little bit? Okay, you take the yaw or the reduction, or there's an error in the guide and you can't tell you've drilled the hole. This way I can tell and see, and if I don't like it, I can change it at surgery on the plan and re-drill it like I showed you on that other case. So this is the workflow. The staff place the fiducials, we scan the patient, they calibrate the machine. I can plan it that morning, I can plan it the day before. Once it's in the system, we work through this, we do sit down, predictable surgery, knowing what we're going to do when we're finished and knowing that we're going to improve the bone with dynamic navigation and with densification, a number of applications. So this was the mantra slide. We want to do stuff that preserves and enhances. We want to reduce risks, and we want to improve outcomes for our patients. We want it to be cost effective. We want it to be efficient. And guys, we want it to not hurt, okay? I've done this on family. I've done this on lawyers. I've done this on patients I didn't want to treat because it's predictable. It's predictable. And it's simple. And the older I get, the more simplicity I want. The more I want predictability and I want simplicity. I'm not sure that, like the our golf bag, there's a whole bunch of clubs in it, but you know, we have our sweet spot ones that we go to all the time, and occasionally I got to take the sand wedge out of my bag. You know, you got to do it, but it's not my favorite club unless I can do an open face full swing, and otherwise I can't hit it very well. But we have to simplify it. And when we look at these areas, combining densification with dynamic navigation, it lets me do everything that I can do with the Densa, and it lets me do everything I can do with dynamic navigation, but I can do each one better. I can change the osteotomy, I can improve the site, I upregulate the wound healing, I do grafting and use amnion chorion for its growth factors, and it's almost all single stage, and it's almost all done at 4 months. Now, I could go to 3 months, but I don't think the soft tissue's finished healing yet. I don't think all the contour changes are done. I don't think it's a mature wound. I'd rather wait 1 more month, and they complain about 4 months, don't they? At least my patients do. Gee, doc, that took forever. Oh, yeah, well, when did we do this? Oh, yeah, well, we did this in October. You're in pretty good shape. Yeah, most people have to wait like 8 or 10 months. Oh my God, I'm so glad I got to do it this way. It really is predictable. And so foundational skills, densification, navigation, these different graftings are critical because when we start marching up the proficiency into the mastery level, that's where we can bend the rules. That's where we understand the game and we can throw the ball where the quarterback or where the receiver is going to be. We can see the play happening before it happens, and that's a real plus when we can climb up to that level. And so with that, guys, I want to encourage you. Any of you have interest and you like going fishing, we set up a meeting with some excellent speakers, Sonia Lisi, Bram Miller, Mike Block, Todd Schoenbaum, and it's a comprehensive treatment planning for surgeons and restorative docs. And it's going to be a fun meeting, and we're going fishing. So if you want to come, love to have you. Look us up. And with that, I want to thank you for your time, and I want to thank you. Thank you.